Following on, I think, from a fantastic first session from Georgie and Kathy, where they really set the context in terms of sleep. What we wanted to do first off was just tell you a little bit about the context for the eSNORE project, and other than it being a fantastic acronym, why we think this is a really important area for research. So I wanted to start off by just saying a little bit about the research context that we are working in. So I'm a clinical psychologist and a researcher at the University of Birmingham, and have been leading research in neurodevelopmental conditions for the last 15 years. And a big part of my early training was working with Professor Chris Oliver in the Cerebra Centre for Neurodevelopmental Disorders at the University of Birmingham. And born out of that centre, a number of myself and colleagues were trained to really think very precisely, very carefully, and I think very clinically about the nature of the challenges faced by children who have rare neurogenetic conditions. And after Chris began to slow down his research, a number of us really wanted to continue the legacy of the work that he'd started in the Cerebra Centre, and have been very fortunate to not only continue that work, but to really grow it across 4 sites. So we have a newly formed Cerebra network for neurodevelopmental disorders, directed by myself, Dr. Jane Waite at Aston University, Dr. Hayley Crawford at Warwick, and Dr. Joan Moss at Surrey. And the central aim of the Cerebra network is to do research that has the immediate or short-term potential to really impact on the lives of children who have rare neurogenetic conditions and their families. And we focused our research across 4 areas, and we think these areas are both fundamental to good well-being outcomes for children with neurogenetic conditions, but also areas that are consistently neglected by research and by policy. So firstly, we've been doing research on autism, the way that autism might present in children with rare neurogenetic disorders. We've been leading work on sleep, and we're incredibly fortunate that we lead that work at Birmingham, so working with colleagues like Stacey and Georgie over the last few years. We've also been leading work on mental health and on behaviour, particularly behaviours that are challenging and that prevent children from accessing school or services. Now, what is critical to the approach we are taking in our research is an assumption that these behaviours and characteristics are not, do not occur in a vacuum, but rather occur in the context of one another, and therefore a research approach to fully understand and improve outcomes has to be holistic. It has to take into account all of these characteristics. And so across the Cerebra network, we are taking up this kind of very joined up approach to try and understand these areas, not in separation, but in the context, in correlation really with one another. And across the network, we've got kind of 4 key questions that we're trying to answer. The first is, can we improve identification in these areas? So if we want to improve outcomes, first off, we have to be able to reliably ascertain that somebody's having a problem with their sleep. And more precisely, as Georgie and Kathy alluded to, what that specific nature of that sleep disorder or sleep problem is. Moving on from that, we want to then be able to build causal models. So here, taking a different example, if somebody is anxious, and we can identify this now, what kinds of things are underpinning their anxiety? Developing more precision for models of cause for children who have neurodevelopmental conditions is essential. There is, at the moment, I think clinically, a bit of an approach where we take what we know from typically developing and we just impose that onto children who have neurogenetic conditions, who might be non-verbal, who might have an intellectual disability. And that has a number of problems. It assumes an underlying similar causal pathway, which might or might not be the case. But it then also assumes that the interventions that work for typically developing children will also work for children with neurodevelopmental conditions. Again, that may or may not be the case, and it's important that we know so that we can not go through a process of trial and error, but can actually just deliver more effective interventions in a more timely way. So we're really interested in ensuring that through research we can build more empirically supported causal models, so that we can develop and pilot interventions. And in some cases, what this means is developing new interventions because our causal models indicate new causes. But sometimes what this means is just tailoring syndrome sensitive, as Georgie put it, interventions for particular groups of children. And then finally, through research, as we've moved through this process, we are really committed to both tracking and then sharing what the long-term outcomes are for children with rare neurogenetic conditions. So as I said, at Birmingham, our particular focus has been on sleep. And I think the talks from Georgie and Kathy earlier on really do demonstrate that sleep is a fundamental building block to good mental health, to good behavioural outcomes. And so it is our kind of primary focus at Birmingham. And so a few years ago, our first Cerebra-funded sleep PhD student, Dr. Jane Trickett, began to try and describe, so that very first question, can we identify, can we describe sleep in tuberous sclerosis complex? And so here what I want to do is just start to narrow our focus for why we've run the eSNORE project that Stacey's going to tell you a bit more about in a moment. So this first piece of work that Jane led used a survey design. It used questionnaires, and we asked parents through these reliable and valid questionnaires to tell us about the sleep of their children who had TSC. We collected data from a relatively small sample, 20 children, but what I would say is in the context of the wider research for children and adults with TSC, this was quite a large sample. And importantly, one of the things Jane did was collect data from typically developing children using exactly the same survey measure. Now, that's a really important part of our approach because sleep is fundamentally a developmental process. There are predictable changes in sleep staging, in the nature of sleep, in the quantity of sleep that happens over the developmental lifespan, as Kathy showed in those hypnograms that change over time, in those sleep needs that change over time. And so when we can contrast sleep in children with a neurodevelopmental condition to children who are typically developing, it can tell us more precisely where the sleep needs might be for children who have these particular neurodevelopmental conditions. So in this paper that we published a few years ago, Jane was able to do that. Just to orient you to the data I'm showing here, what you can see along the side of this table is different categories of difficulties or problems with sleep. And then across the top, we've got different neurodevelopmental conditions, Angelman syndrome and Smith-Magenis syndrome that Georgie touched on already briefly. And then tuberous sclerosis complex, the focus for us today. And then children with autism. And the pluses in this table indicate that this particular area of sleep difficulty is a problem for children with this neurogenetic condition. So what we start to see is that across neurogenetic conditions, there are unique profiles of sleep difficulty. Now, this is really important because what it begins to tell us is that there might be specific needs in specific syndromes. And it also starts to push us along that model of kind of being able to model cause. So if in one syndrome, there is a very high level of a particular sleep difficulty, but in a different syndrome, there's a very low level of this particular sleep difficulty, that might tell us something, it might allude to something in that causal pathway. So in tuberous sclerosis complex, compared to typically developing children, we saw that children had some difficulties with falling asleep at the start of the night. They had a longer sleep onset latency. They had some difficulties with night waking, and then some difficulties with severe early morning waking. So all of these we might think of within that broad category of insomnia that Georgie touched on at the beginning. We also saw difficulties around parasomnia, so those unusual nighttime behaviours that Kathy began to talk about, and some difficulties with daytime sleepiness, which may well be a result of these other sleep disorders that we've mentioned. What Jane was also able to show is that children with TSC were much more likely to co-sleep, so to be sleeping with their parents, than the typically developing children. And critically, that their sleep disturbances were correlated with the severity and frequency of health conditions that their parents reported. Now, for both of these associations, the higher likelihood of co-sleeping and the sleep disturbance being related to health conditions, this association was unique to the children with TSC. So we didn't see that in our autism group, we didn't see that in the Smith-Magenis or the Angelman syndrome group. The final thing that Jane was able to show was that the sleep disturbances for children with TSC were related to some of their daytime challenges. So being more overactive and impulsive during the day was correlated with sleep problems as reported by parents. So this initially gave us a really important picture of some of the more specific challenges for sleep for children with TSC. But there were some big problems with this data set. So we were essentially asking very tired, potentially already overburdened parents to fill in these questionnaires for us. And this is a common problem with sleep methodologies in neurodevelopmental conditions, because we are relying on parents who may already be very tired to report with real precision about their children's sleep. We're asking parents who might have been woken 4 or 5 times in a night to tell us when they were woken for that 5th time, did their child wake up for 6 minutes or was it in fact 8 minutes? And that degree of precision is simply not possible. But also we're reliant on parents being aware of all of those types of sleep difficulties, all of those wakings, all of those difficulties in falling to sleep. And that may not always be the case if children aren't always showing those signalling behaviours that Georgie talked about. And so we felt there was a need for a more advanced and more robust study that used more direct methods of sleep assessment. And so under the brilliant leadership of our postdoc fellow, Stacey Bissell, we brought together this team of experts in sleep, experts in tuberous sclerosis complex, to pilot what fortunately turned out to be a very robust method using entirely remote pandemic-proof sleep assessment technologies. So we have been using actigraphy. This is a direct technology to monitor sleep that Stacey's going to talk to you about a bit more in detail next, and a mobile phone app to collect data on sleep, behaviour, seizure activity and physical health in children with tuberous sclerosis complex. This is the first study of its kind internationally that's collected such a large amount of data on the largest group of children with tuberous sclerosis complex. And we're really excited to be able to share the findings of that study with you today. So without further ado, I'll hand over to Stacey to tell you more about that.
Hi, thank you very much. So I'll just introduce myself. So I'm Dr. Stacey Bissell, and I did my PhD with Professor Chris Oliver and Dr. Lucy Wild, looking at behaviours in TSC. So I've actually been doing TSC research now for about 8 or 9 years, I think. And I'm really excited to be able to talk to you today about sleep and behaviour in children with TSC in a little bit more detail. So as I'd already mentioned earlier this morning, the sleep in the context of TSC is really important because there are a lot of co-occurring factors in TSC that we already know are associated with poor sleep. So in any of these individual conditions, we will see that sleep is affected. And there are good guidelines in place for any of these individually, so in relation to ADHD or in relation to autism. But TSC is a lot more complex than any of the single co-occurring conditions. And as Georgie mentioned, if we just take intellectual disability as an example, we see elevated rates of all of the sleep disorders compared to typical development. But as I keep coming back to, sleep in TSC is much more complex than that. TSC in itself is a very complex condition. And it's what parents actually, I think, struggle with that description, is that it's complex and it's variable and there's variability in the degree of severity. It's not just intellectual disability that is a factor in TSC in relation to sleep. So if we take this graphic here of all of the factors that may underlie sleep problems in relation to developmental delay, in TSC we'll also see nocturnal seizures, the effect of anti-epileptic medication, and the impact of secondary health conditions and its relationship with pain, as Georgie has already alluded to. But then there are these psychological factors that we need to take into account, especially in relation to anxiety, depression, and having an additional diagnosis of autism or ADHD. And all of these are of higher prevalence in individuals with TSC. So there are lots of co-occurring factors in TSC where we know sleep would be implicated. And I'm not going to dwell on this slide too much because we have Professor Petrus de Vries in the next session who will go into much more detail about TAND. But I just wanted to present to you this umbrella definition of TAND to just really highlight how complex a condition TSC is. And so you have the different levels of TAND, and we see that sleep problems falls under the behavioural level of TAND. So to even be considered one of the TAND manifestations, it must be of clinical concern because it must be something that comes up in the TSC clinics and that families talk to clinicians about. And so if we look at data from the TOSCA registry, so this is the TSC registry to increase disease awareness, TOSCA, and it's one of the largest registries of TSC internationally. The consortium looked at TAND data from within the TOSCA registry. And the first thing to point out is the number of individuals where no data was available at baseline first off. So there's that real treatment or assessment gap in TSC that we also need to take into account. So individuals didn't have data about some of these TAND features. The other thing to draw your attention to is that we saw that some of the behaviours were reported at higher levels in children under the age of 18 compared to adults. So we see, for example, overactivity and impulsivity were higher in children with TSC, and TAND features such as anxiety and depressed mood were higher in adults. But we see that sleep difficulties were equally prevalent in children and adults, and they were the second most common TAND manifestation. So they occurred in 44% of individuals, both children and adults. So that's the first take-home message, that sleep problems are prevalent in both children and adults with TSC. The difficulty with measuring sleep in TSC or any genetic syndrome is that you have variable assessments and you have different assessments that you can use. And there are pros and cons to both, and not one is recommended over another. They both have their utility. So some of the direct assessments, actigraphy, I'll be going into a bit more detail. It's a watch light device that's worn on the wrist or ankle as a proxy measure of sleep. So it uses movement to calculate sleep periods. And then we have polysomnography, which is what we would see in a sleep clinic or an overnight laboratory study. And video somnography is the use of behavioural recordings alongside in clinic assessments using polysomnography. And when we talk about informant report measures, this is what Caroline was alluding to. These questionnaires, these parent report questionnaires and sleep diaries that individuals either fill in for themselves or on behalf of the individual they care for with TSC. And there are examples of sleep diaries in the Cerebra Sleep Guide. So again, one isn't more preferable than the other. Arguably, direct assessments are more accurate, but the con being that they are potentially invasive. Informant report measures are quicker to administer, much more low cost, but they're time intensive for parents to complete. And so Caroline has already presented a little bit of this data from Jane Trickett's work looking at the modified Simmons and Paragus sleep questionnaire, which is a informant report measure for parents to complete on behalf of their children. And this is another table from that paper where we have running down the side of the table the sleep subscales from the MSPSQ, and then along the top the different neurodevelopmental conditions. So I just want to draw your attention to where TSC differed to typical development. So in terms of night waking, parasomnias, and daytime sleepiness, we saw that higher rates reported in children with TSC compared to typically developing peers. And just to draw your attention back to the direct assessment, so polysomnography is considered the gold standard. But as you can see, even paediatric polysomnography is highly invasive. A child is in an overnight sleep clinic, sleeping away from the family home. They're unlikely to get a good night's sleep given that the unusual sounds, they're in an unusual setting, it's unfamiliar, it's quite scary. So we favour the use of actigraphy. So there has been one polysomnography study, which was really important in the early 90s. I think it was with quite a small sample of 9 children where they conducted polysomnography and were able to compare polysomnography to typically developing children. And this early study from the 90s found that children with TSC did indeed evidence reduced total sleep time, reduced sleep efficiency, decreased REM sleep, and more frequent night wakings. This was a single night polysomnography study with a very small sample, and nothing's been done in children in terms of a direct measure of sleep since that time. And so polysomnography definitely has its place, especially within a sleep clinic. In terms of research that's ecologically valid, we at the Cerebra Network, as part of the Richards Lab, we favour the use of actigraphy because we think it's more tolerable in terms of being able to be worn by the child during their day-to-day activities at home. And this is the model of ActiWatch we used in the eSNORE study. So it's a Respironics watch, and this is what an actigraph looks like. So this is the sleep data that we get back at the other end. So I'm quickly going to talk through the sleep parameters that we measure using actigraphy. This is quite a complicated method of assessment if you're new to actigraphy. So across the top, you've got 12 midnight to 12 midnight. So if you can imagine within 12 noon to 12 midnight. So one day goes from 12 to 12 with the middle period. Sorry, I've confused myself. We've got 12 noon to 12 noon with 12 midnight falling in the middle. So it goes from one day to another, if this makes sense. So this is the Monday evening going into the Tuesday morning, and then the Tuesday morning falling down here, going into the Tuesday night, going into the Wednesday morning. And when you see black spikes, that's level of activity. And when you see low levels of black spikes, that's when the actigraph interprets that the child's asleep. And so it will generate and automatically generate a sleep period based on when the levels of activity drop to minimal levels, and then when they resume, the actigraphy then interprets that that period of low movement is a sleep period. And we can supplement this with data that the parent provides to us in sleep diaries as well, to sort of clean the data. And from this, we get their overall total sleep time. But what we're also interested in is when these black spikes of activity occur within these solid blue bars of sleep, because that would indicate to us something called wake after sleep onset. So that's when the child is moving or awake, that affects their sleep efficiency, because it's telling us they're awake or they're moving when they should be asleep. And so that brings us on to the eSNORE sleep and behaviour in TSC study. So eSNORE stands for Exploring Sleep in Neurodevelopmental Disorders Through Online and Remote Evaluation. So more than anything, the eSNORE study was a pilot study of this methodology and using new remote methods in a neurodevelopmental disorder, with TSC being a neurodevelopmental disorder. So it's a direct study of sleep in children living in the UK aged 4 to 15 with a confirmed diagnosis of TSC. And so children were wearing the ActiWatch day and night over consecutive nights. So that's where the difference is in terms of its novelty compared to previous polysomnography studies that were over a very short period of time, a single night's direct assessment of sleep. This, we were collecting up to 10 days worth of sleep data. So children were wearing the watch during the day and during the night. And we also recruited an age-matched, typically developing group of children. So both groups were wearing an ActiWatch. And we had 3 aims or 3 research questions for the eSNORE study. So we wanted to compare sleep parameters in children with TSC to a typically developing contrast group, using actigraphy for the first time in this group, to model the contribution of physiological and psychological variables to the profile of sleep in TSC. So we've already talked about some of those. So some of those physiological and psychological variables being pain, seizure severity, behavioural observations such as overactivity, and to also describe associations between night-to-night variability in sleep and day-to-day variability in those daytime behaviours. So self-injury, aggression, overactivity, pain, seizure severity. So first, I'll start by addressing the first research question, which was, were there any differences between a TSC group and an age-matched TD group in relation to sleep? So I'll be doing this by comparing MSPSQ subscale scores between the 2 groups, as Jane did in her previous study. And so the reason that I wanted to present this data to you here today is that we were carrying out this study during the pandemic, and there are different groups of children from Jane's cohort. So we have a more recent cohort, so we had more variables that we could look at in terms of the context of the pandemic. And for the first time, compare actigraphy between these 2 groups, which has never been done before. So as I said, this is a direct study of sleep in children with TSC with a confirmed genetic diagnosis. So the first stage was that parents would complete online questionnaires and provide a saliva sample if we were at that point where we were still at the university before March 2020. And also ask parents to complete the sleep-specific questionnaires. Then we also obtained measures of seizure severity, adaptive functioning, and other aspects of TAND in terms of diagnosis and schooling using the TAND checklist. And then the direct sleep assessment, which is where we'd send out the ActiWatch to the family in the family home and ask parents to download the eSNORE mobile app. And I'll go into a bit more detail about the mobile app, but this was completed alongside the child wearing the ActiWatch to supplement that actigraphy data, because it doesn't always come through as clean data. Sometimes we need information from the parent in terms of when the watch was taken off for sport or for swimming, or if the watch, someone forgot to put the watch back on the next night, for example, they could be misinterpreted as sleep periods. So we need to supplement that with the mobile app data. So as I said, we also administered the MSPSQ as Jane had done in her previous TSC study. And the novelty of the eSNORE study is that we get to compare actigraphy profiles, and Jane didn't have actigraphy data in her previous study because we were first just initially describing whether sleep was an issue in children with TSC. So first I'm going to present to you the new MSPSQ data, which is an extension of what Jane had previously done. So we were interpreting significant differences at P.01. And we, like Jane, we had 20 children. So we had questionnaire data for 20 children with TSC and 20 age and sex matched children. And as you can see, they were well matched in relation to chronological age and sex. And then here are the MSPSQ subscales. So the ones highlighted in blue, night waking, parasomnias and daytime sleepiness, were the subscales where Jane in her previous cohort, which was a 2014-15 cohort, found significant differences. What you can see highlighted in the column in orange were the ones that were significant from our eSNORE study, so during the period 2019 to 2021. And as you can see, there are now 6 significant subscales between the TSC and TD groups. So unlike Jane's study, we found that sleep anxiety was a factor in TSC, bedtime resistance was a factor in TSC, and now sleep disordered breathing as well. So that was a replication of the questionnaire data, but we, in this study, wanted to pilot the use of actigraphy and this mobile app for the first time in children with TSC. And for this, we didn't have actigraphy data for 3 of the children. So we needed to exclude their data for a number of reasons, or they weren't able to tolerate the watch for the full duration of the study. The key thing to point out, so our actigraphy measures, we can obtain information on the time the child went to bed, the time that they woke up, the time that they spent in bed, their total sleep time, and from that you can calculate a sleep efficiency. So percentages closer to 100 means that the time that you are in bed is the time that you're asleep. So anything closer to 100 is better sleep efficiency. Sleep onset latency, so how long it took to drift off to sleep or to fall into sleep, and then wake after sleep onset. And so the key thing from this table, because there's a lot of numbers in this table, there were no significant differences on actigraphy between the TSC and TD groups. So this would then lead us to think, well, parents are reporting that it's an issue. It's highlighted as a TAN behaviour. Individuals report to us that they have difficulties with sleep, yet we're not picking it up at group level, at least, using actigraphy. So if you eyeball the data and eyeball individual actigraphs, based on those group statistics, we would be led to believe that sleep in TSC wasn't a problem. Parents might be reporting it, but we're just not measuring it directly. But that's simply not the case, because if you compare like for like a child with TSC to their TD peer and look side by side at their actigraphy, you would not say that they are the same. So I'm going to highlight an example of this. So here's the actigraph from a 5-year-old male from the typically developing group. And what we can see here, you see periods of activity during the day. These are periods when the ActiWatch would have been taken off for a bath, for example. Activity, and then a solid blue line around 8 o'clock. So that's the child's bedtime. A pretty consistent blue bar of solid sleep, slowly coming out of sleep at around 5 a.m. and waking up to start the day after 6 a.m. What we see in TSC is something different for some of these children. So don't get me wrong, some of the TSE data does look like this, but some also looks like this. So the key difference here is that we don't see these solid periods of consistent sleep. We see this more fragmented sleep pattern. So here, for example, on 2 of the days, the child seems to have a fairly consistent sleep time at around 8 p.m. But there's a couple of nights where that sleep's really short. It's a really short period of sleep, with the child waking around, you know, anywhere between 1 a.m. and 3 a.m. and not just waking, but being active, and not settling back to sleep, but being up and active. And then what we also see in TSC, which we think is relatively novel to the TSC group, because we haven't picked up on this in Smith-Magenis syndrome or Angelman syndrome in this sort of context, is a return to sleep in the late morning, this late morning nap, which is quite interesting because daytime napping is discouraged around this age, 5 to 6, when a child will be going back to school. And so what we were seeing in this little boy with TSC here was that he was on an anti-epileptic medication, and he would come out of sleep at around 3 a.m, wake up, go downstairs, have his breakfast, have his morning dose of the anti-epileptic medication, which would then make him drowsy enough to return for a late morning nap. So why this questionnaire data is important is because on 6 of the 7 informant report subscales, we see a difference between the TSC and TD groups. So we see an increase in the number of affected sleep parameters in this more recent cohort than the 2014-15 cohort. And we think this is likely to be as a result of the change in routine as a result of COVID. So with a move towards homeschooling, an inconsistent daytime routine around parents being at home, for example, and also the uncertainty around everything to do with COVID. That's why we might now be seeing those sleep anxiety and bedtime resistant sleep parameters coming up. However, children with TSC did not evidence significant difficulties with, you know, the sleep parameters around settling and waking and wake after sleep onset when we looked at the actigraphy data. I don't think this is the whole story, because we were looking at that at group level. And when you compare the two side by side, as in the previous example, there's more to the story than a group level. And in TSC, more than most, it's so variable that grouping children in this way might not be the best approach. So it is important to adopt this multifaceted and individualized approach. So now I'm briefly going to touch upon the second research aim, which was to really understand what are the physiological and psychological variables that may be underlying the profile of sleep in TSC. So we go back to Jane's paper, and Caroline has presented these results as well. That according to questionnaire data, children with TSC evidencing reflux, so stomach acid coming back into the throat and being very painful, obtained higher sleep onset latency scores and night waking scores. So they took longer to fall to sleep at night, and they woke during the night. And that night waking and parasomnia scores positively correlated with overactivity. However, this, as I said, this is based on informant report questionnaire data, and there's nothing wrong with informant report questionnaire data at all. But we had a unique opportunity in the eSNORE study, a really novel opportunity to capture these variables that we wanted to know more about in a unique way. And this is where the eSNORE mobile app comes in. And the eSNORE study was more about piloting methodology in addition to all of the results I'm presenting. These were really novel methodologies that we were using. So what we actually did, we developed an app where parents weren't completing a paper sleep diary, which could get lost or is quite intrusive, or you have to really think about having to fill those in. This was all captured on an app. So we had a sleep app within the eSNORE mobile, sleep diary within the eSNORE mobile app. And this was just an electronic version of a sleep diary. But what we were also asking parents to do every evening and every morning, alongside their child wearing the ActiWatch, was to record behavioural and pain observations. So we actually had a mobile app version of the FLAC built within the app. So every morning at wake up, the parent would fill in the FLAC, and every night before bed, they would fill in the FLAC. So it gave us a really good indication of whether the child was in pain at bedtime or in pain at waking. And then we also had behavioural measures. So we were asking parents to rate the severity of overactivity, property destruction, self-injury. And I'm highlighting overactivity because that was one of the psychological variables that underpins sleep, according to Jane's work. But what we also wanted to capture was day-to-day, night-to-night seizure severity. So I just want to really quickly introduce some new data. So what we were able to do using the eSNORE results was to look at the highest rating of pain and seizure severity and overactivity. And those are the variables I'm going to concentrate on today, just in the interest of time. Taking the night rating that was highest, so when a parent was given a rating of 4 and 5 and 3, and then looking at the next on an evening, and then looking at what that did to the next night's sleep. So sleep that night, if a parent had rated overactivity and pain, filled it in at 8 o'clock, child went to bed, what did their actigraphy for that night look like? And then compare that to their lowest period of pain rating, overactivity and seizure severity. So here we were doing within group statistics, looking at using each individual child and comparing their highest levels to their lowest levels and seeing whether there were differences in sleep parameters if we did that. So here I'm going to present these actigraphy sleep parameters, and we're comparing the highest rating and the lowest rating for pain, overactivity and seizure severity, and looking within the individuals whether there's any differences if we compare their actigraphy following a high period of pain compared to a low period of pain. Do we see differences in sleep? So we're looking for significant p-values at less than 0.05, and I'm really going to race through these because the take-home message is that there were no differences between highest and lowest ratings. So what can we conclude from that? So that I've presented to you now 2 actigraphy results, TSC TD comparison, and then within TSC comparing highest and lowest levels. And I'm telling you that there are no significant results. But what's really important is the direction of difference. So what we did was look at evening behaviour and how that had a knock-on effect on the sleep of that night. But we know that in correlational data, is it the overactivity driving the poor sleep, or is it the poor sleep driving the next night's overactivity? Is it a restful or not having a restful night's sleep is driven by pain, or is it the lack of sleep driving a higher rating of pain? So it's difficult to conclude using the statistical methods I've just presented. And that brings us on to the third aim of eSNORE, which is still ongoing, is to describe those associations between night-to-night variability in sleep and the day-to-day parameters that were measured via the mobile app. And how we're going to do that is by taking, each child has so much data, because we were collecting data for up to 10 nights, that we have the capacity to do within group multi-level modelling and take each child's individual night's sleep as a data point. So that's really exciting, where we might be able to then tease apart the direction of the factors of how they're associated, what's driving what, because we know that poor sleep is a factor in TSC, but we're just not highlighting them using our current statistical techniques. And to just dwell on that fact a little bit more in terms of complexity, these are all the things in TSC that have been found to be associated with behaviour. this eSNORE project and all the data that we've got from it is our opportunity to really understand whether poor sleep is underlying any of the TAM behaviours such as self-injury, aggression, property destruction that we were able to measure from the eSNORE mobile app, and really explore what's driving some of these behaviours. Is sleep a potential factor, or is the relationship the other way around? Do behaviours impact a night's sleep, or is it the night's sleep that's impacting the daytime behaviour? So thank you very much for listening, and thank you so much to all the parents and children who have taken part in the study over the years, and it was really nice to be able to see many of the families from my PhD work, and I'm really happy to take any questions.